Good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well. All apologies for the setting. I understand it's very dark and the audio quality may be a bit dubious. I'm currently spent the weekend a few hours, several hours from where I live up in the mountains of the Lincoln National Forest as opposed to the Gila National Forest. So I was up in the Cloudcroft, New Mexico area getting some high altitude mountain biking in. I'm on my way back home, but I wanted to do a video covering some data that came out toward the end of last week, and that is on a potential therapeutic candidate for COVID-19, an antiviral medication known as molnupiravir. Molnupiravir was originally developed as a potential treatment or potential therapeutic for influenza. And then, of course, COVID-19 happened in 2019, and there has been a phase 3 clinical trial that has been looking at this agent. And essentially what they did is they started recruiting patients or people. Approximately 1,600 is what they wanted to do. And this involves multiple centers, multiple countries around the world. So from what I can tell, and I want to be very clear that this is essentially press release information, so we're not privy to any of the peer review or any of that. So let's keep that into context, or take that into context. At this point, it's just a peer review, so we have very limited ability to really look at the data. But what I see in the press releases is that they recruiting approximately 1,600 people across many different countries, and essentially what they did is they took a group of about 760 or so people that would get molnupiravir, and about that many who would receive essentially a sugar pill or a placebo. And the people that they recruited all had to have at least one risk factor for severe COVID. So think of diabetes, hypertension, obesity, heart disease, lung disease, immunocompromised, etc. And they were all adults that were unvaccinated. So, definitely people are going to be at higher risk for developing complications if they in fact got COVID. And then they started looking at the difference. Essentially what happened is if people in the treatment arm, these 700 some people that would receive the treatment, and again this is all randomized, if they had symptoms of COVID, they would receive this medication, molnupiravir, and they would begin taking it orally. It's a BID, or a twice daily pill for 5 days, so it's 10 pills twice daily, for a total of 10 pills. And in the placebo group, they'd essentially receive a sugar pill twice daily. Again, so nobody really knew who was getting the actual medication and who was getting the placebo. And they ended up actually terminating the study early. That is to say that they only recruited about 90% of the 1,600 or so people that they wanted to recruit, because there was apparently such a strong signal in the molnupiravir group, and that is to say that apparently this has the results were incredibly promising, or are incredibly promising, and so it was terminated early because it would be morally and ethically dubious to continue to give people placebo in light of apparently such an effective agent. Well, let's talk about what they found. And again, press release, not peer reviewed, so we're not privy to all the information yet. All right, so let's caveat that. So what they found was in the 770 or so people that got molnupiravir, they would begin taking it within 5 days of the onset of their signs and symptoms. That was one of the criteria. So they could not be hospitalized, and it had to be early on, and that makes sense because the first week is the viral phase of COVID-19. By the time you get into the second and third week, you're really not dealing with virus at that point. You're dealing with the immune response, or a maladaptive immune response, presumably. So within the first 5 days of symptom onset is when these people would begin taking either the placebo or the molnupiravir active agent. And they found, comparing the two groups, they found approximately just a little over 7% of the molnupiravir group ended up hospitalized, whereas just over 14% of the placebo group ended up hospitalized. Furthermore, there were no deaths in the molnupiravir group, whereas there were about 8 or so deaths in the placebo group, and there were approximately 50-some people that ended up getting COVID in each group, right? Give or take a couple, but pretty comparable numbers, all things considered. You're looking at an approximately 50% reduction in hospitalization and no deaths in the treatment arm of the group, and that's why this was terminated early, because this is actually a pretty strong signal. Furthermore, they did publish some data, or they rather presented some data. Again, this is preprint, non-peer-reviewed, about some of the side effects. And interestingly enough, the side effects profiles were remarkably similar between molnupiravir and placebo. About a third of people had substantial side effects that received molnupiravir, and about 40% of people reported having significant side effects in the placebo group. And so essentially there's just no big signal there, so that does suggest that that this medication has a fairly good safety profile, and all the side effects are going to be remarkably similar to somebody who's receiving a sugar pill in essence. So these are more likely psychosomatic side effects due to the placebo effect. That's one of the main reasons why we have randomized, blinded, controlled trials to account for the placebo effect. So you can see that that's actually a good finding there. A third of the people in the treatment group had signs and symptoms, side effects, whereas 40% thereabouts of the people in the placebo arm ended up having side effects. So that's good. That does demonstrate some safety. Some safety data there. And so that's kind of the crux of what was presented. So let's just talk a little bit about what molnupiravir is as far as an antiviral agent. And I won't go into the weeds too much, but essentially what it is, it's first of all, it's considered a prodrug, and a prodrug is just a drug that it's in an inactive form when you take it, and then typically what happens is once it gets into your body, it gets metabolized and turned into its active form. A classic example, this would be something like aspirin. When you take aspirin, it's actually inactive. Aspirin is actually acetyl salicylic acid, and then when you ingest it and it gets into your body, the acetyl groups are cleaved off by enzymes, and it is converted into its active form, salicylic acid, right? Codeine is another example of a prodrug. When you take codeine, it gets demethylated and converted into morphine, and there are many examples of this. But molnupiravir is a prodrug, so you take it, it gets metabolized or biotransformed, converted into an active form, and essentially what it does is it mimics the ribose sugars that are used to create the RNA. They form the RNA backbone for the RNA that the SARS-CoV-2 virus would use. So when the virus gets into your cell, it essentially throws messenger RNA into your ribosomes, and that tells, quote unquote, the ribosomes how to make viral proteins, and then those proteins self-assemble, and then you get new viruses, and then they bud out, and so on and so forth. So molnupiravir is kind of like a Trojan horse in that it mimics the ribose sugars that are used by messenger RNA, but it's not the exact ribose sugar that's needed. And so what happens is these molecules get integrated into the RNA sequence of that virus, and essentially what it does is it just initiates a massive mutation, just causes massive mutations, and it's just completely lethal, and the virus is completely incapable of creating proteins that can self-assemble and function, and it just stops the infection dead in its tracks, so to speak. So that's the basic high-level overview of the mechanism of action of this particular agent, and that's a high-level overview of the currently available information. So this is actually fairly compelling because currently we don't have great antiviral therapies. Actually, we don't have any aside from like remdesivir, but if we're being honest, the data for remdesivir is very low quality. It's very poor, and most people are not consistently using remdesivir to treat severe COVID-19 or to treat people who may be at risk for severe COVID-19. So this could be a potential breakthrough for treating COVID-19, at least keeping people out of the hospital and keeping them from dying, at least adult patients. But we shall see. Clearly this is good, and if this pans out, this is promising. But again, just like my prior videos when I talked about other potential therapeutics, i.e. ivermectin, I am going to hesitate in singing the praise of this particular agent, molnupiravir, until we can actually see the data and it's discussed and the scientific method is properly used. So I feel I need to be consistent and intellectually honest in the way in which I engage with these things. So this is actually a very compelling, but at this point, it's something I'll continue to watch. If it does pan out, I think it could be a good thing. First of all, it's an oral agent, so it doesn't involve parenteral administration like we see with the monoclonal antibodies, where they have to be administered intravenously or possibly subcutaneously in some cases. So from a logistical standpoint, this would be good. This could keep people out of the healthcare setting, keep them at home. So it is interesting, it's compelling, and we'll see what happens. So at this point in time, that's all I can really say about this new development. But I just wanted to get this video out, and hopefully you all found it helpful, and hopefully you got something out of it in spite of the rather dubious audio and visual quality. Alright everybody, take care, stay safe, and we'll see you in the next video.